Good day, listeners and parents. Let's jump right in and talk about the 10 common things that happen to the newborn in labor and delivery. My name is Dr. Anyoha. I am a board-certified pediatrician and hold a PhD in infant mental health and early childhood development. This is to say I have interest in the social-emotional health of babies, the newborns, and infants and children. And as part of my regular topics, I'm going to talk about what happens to the newborn in labor and delivery. As a pediatrician, I'm always called, I won't say always, but sometimes when the delivery team needs me, they call me or they invite me to labor and delivery to assist with the newborn should anything go wrong. So I go in there and, once as I'm waiting, I witness, a few things that I think the parents need to know, and I want to bring it to the attention of parents, especially and have that as a knowledge base, and of course discuss with their families and older siblings and friends. Information is power, right? So let's jump right into it. So the number one is babies are suctioned in their mouth and nostrils once they're delivered, and they have materials like fluid around their mouth and nostrils, especially if the baby is born and they're not crying. The first thing the OBGYN doctors or midwife attendants do is to suction the baby gently in the mouth and nostril, and to allow air to begin to enter into the baby's nostrils so the baby can start breathing. So I think that's the first thing I notice that happens frequently. The second thing I notice that happens frequently is, of course, once the baby is born, simultaneously, there's a clock around the corner, and a nurse or an attendant looks towards the clock and then records the time, time of delivery, because that's going to go into baby's record, right? Every baby, the date of birth, the time of delivery is well recorded and is done when the baby is fully born. So I think that's number two thing that happen in labor and delivery that parents should know about. Number three thing is, of course, cutting the cord, which is a big deal. You put two clamps and then cut the cord in the middle, right? One clamp and the remaining of the cord goes towards the placenta and the mother. The other section of the cord is with the baby and goes to the pediatrician, right? And eventually the baby ends up under a radiant warmer where a baby is placed to continue to be looked after, right? So number three thing that happened to the baby is cutting the cord, right? And number four is the baby is handed over to the pediatrician and the nurse attendant, usually the pediatrician works with a nurse attendant to make sure the baby is okay or continue to be okay. And most babies are, but the radiant warmer is the place where we care for the babies who are not doing very well and who needs to pick up and start crying. Okay, so what do we do there? If the baby still has some materials, fluid around their nostrils, and the mouth will suction the mouth and the nostril, okay? Clearing the airway so the baby can breathe. And then, of course, there's plenty of warm blankets. We continue to mop the baby's skin, get rid of the amniotic fluid. The head is a good, is soaked with fluid and sometimes blood. So you need to get that out so that the baby could remain warm and not to lose temperature from the evaporation of fluid. All right. So we do that, and of course, under the radiant warmer, pulse oximeter is attached so that we know that the baby is breathing very well. Oxygen is saturated, and the heart rate is beating good. Right. So the heart rate is within normal limits. So pulse oximeter is attached, and the nurse can get the height and weight of the length and weight of the baby at that point in time, because the radiant warmer has ways to measure weight, and the nurse can use a tape measure to measure the length of the baby, right? And still under the radiant warmer, a quick exam is done. Okay, looking over the baby to make sure the baby is okay, and check for any gross abnormalities like extra digits, extra skin tag, head deformity, bumps on the head, and stuff like that, right? So the baby is checked out quickly, and they of course part of the assessment is to do what we call ABGA score, right? ABGA score, the highest the baby can score is 10. And most babies do score 9 ABGA score. ABGA score is checks for baby's heart rate, make sure it's strong and within normal limits. Baby's respiratory rate, respiratory effort is also checked. Muscle tone, grimace. How is the baby reacting to, things around them? Are they sneezing? Are they coughing? Are they just not responding? So you want to know that. The more the baby responds, the better, right? And of course, you check the skin color and whether the extremities, the baby is pink, right? Which means that the baby's oxygen is flowing everywhere. But most times, the foot of babies are usually, slightly blue, we'll call it. So most babies end up getting ABGA score of 9 at 1 minute and 9 at 5 minutes, right? So the maximum a baby can get in one category is 2, right? So, and there are five categories, like I said: heart rate, respiratory effort, muscle tone, reflexes, and color. So if a baby who hits 2 categories, the baby gets 10, right? But usually the color is 1, because most babies, like you said, have this tinge of blue on their feet, which is normal. So we give them 1 instead of 2. So if you add them up, 5 categories, 4 categories of 2, and 1 category of 1. So most babies get an ABGA score, or most babies get ABGA scores of 9 and 9. So you don't have to be very nosy about ABGA score, but it's good for parents to know that this ABGA score is a way of assessing how their baby did at age 1 minute and age 5 minutes approximately, right? And sometimes we do at age 10 minutes as well. So I don't want you to be confused when you see ABGA score in your baby's document, right? It's just a gross way of, overall way of measuring how the baby did at birth, right? So that is the 4th thing, we do. And of course, after that, the 5th thing that usually occur is erythromycin on the baby's eyeball, I should say, in the baby's eyelids, right? You open the eyelids and you put the erythromycin ointment there. They come in a small tubes, right? So you open that and squirt some in each of the eyelids, right? And that is to prevent gonorrhea. Pregnant women and women who are going to have a baby are screened for gonorrhea routinely, which is a standard thing in the United States. But as an extra precaution for cases that might have been missed, right? This erythromycin is put in the baby's eye to prevent risk of eye infection due to gonorrhea, which could cause devastating eye problems in babies, right? So you want to make sure your doctor screen you for gonorrhea and chlamydia. But the erythromycin is specifically for to prevent transmission of gonorrhea from the mother's genital tract to the baby's eye. All right. So that is the fifth thing that happens, which is erythromycin ointment to the eyelids. The sixth thing that happens is vitamin K shots. Babies receive 1 milligram of vitamin K in their muscle, right? When they're born, while they're still under the radiant warmer, right? Placed on the radiant warmer, and after suctioning and doing other things we talked about, there's a shot of vitamin K that is placed in a baby's thigh, right? And usually we don't put a band-aid there, so parents don't even know that this was given. But vitamin K is very important because it helps facilitate the clotting mechanism in a baby. Clotting mechanism is very important because that prevents the baby from bleeding inside the muscle or in the abdomen or in the brain, which might cause serious brain problems, lethargy, brain damage. So you don't want the baby to be at risk for bleeding inside their cavities, right? Inside the brain or muscles. So that's why vitamin K is very important. Even babies who are born at home by midwife might be at risk if they don't know about the importance of vitamin K. Vitamin K is used to facilitate clotting mechanism to prevent babies from bleeding after they're born. So that's very, very important to know. So another cool thing that happen in babies in labor and delivery, that is number 7, is babies are footprinted, right? An attendant brings an ink pad and places the baby's foot on the ink pad and then transfer that to a paper that is going to go to the baby's documents, right? So both baby's feet are footprinted and placed on the paper, and it's going to be part of the baby's document that the mother goes home with, right? So I think it's part of the identification process. And of course, once the baby is born and the information goes to the record department, they also bring a wristband that goes on the baby's wrist, all right, for also identifications. So as early as 1 hour of age, babies are beginning to get into the system of footprint, ID bands, and being, introduced into the society way of doing things. So parents have to know these things happen and be prepared to discuss with their doctors when they take the baby to routine newborn visits when they're discharged from a hospital. So, but we're still in the labor and delivery, right? The baby is still there with the mother. So the 8th thing that happens is what we call skin to skin. Now this baby is stable, right? We know the baby is doing well. The baby's breathing color is good. Vitamin K shot is given. Erythromycin is also given. Put in the eyes. So we're now to number 8, which is skin to skin, which is a way of starting early bonding, mother and baby bonding, right? So the baby is transferred to mother, still on the delivery bed, right, and placed on the mother's chest, and this baby is cozying up on the mother's chest, right? And the mother feels the love and the touch of the baby, and it relaxes the mother and relaxes the baby. And this is the beginning of bonding, which is the very big thing now in pediatrics, right? It's called skin to skin bonding. All right. So that is the 8th thing I think that's cool that happens to babies in labor and delivery. The 9th thing is for the babies to be retrieved from the mom, and covered and dressed up in a warm blanket, right? And with their hats on. This is also to prevent hypothermia or loss of temperature for the baby, this is to prevent a baby from being cold, right? Especially now in countries like United States or Western country where, or usually in the delivery room, the temperature there is very cold. And babies can get very, very cold, right? So once the baby and mother are done with the skin-to-skin bonding, the baby is wrapped in a warm blanket and a cozy hat. And that's number 9. So number 10, what's number 10? Number 10 is this baby needs some rest, right? So the baby is put in a bassinet, right? And where the baby is resting. Because this baby is born and has been through all this traumatic experience of things in their nostrils, bulbs, syringe suction in nostrils and their mouth, ointment in their eyes and a shaft in their muscle. So this baby get some rest. So the baby is put in a bassinet, right? And that goes with the mother to the mother baby unit if the mother is ready. If the mother is not ready, then the baby stays beside the mother and the father and waits for the next thing. So now you know what happens in that labor and delivery room. It's no more a mystery, right? And this is important so that the parents can discuss these some of these things with their baby's doctor when they go for appointment, right? Which is within a week of delivery. You should take your baby to your pediatrician, right? And be ready to tell them exactly what's going on, what happened in that delivery room. Okay, what is the baby's ABGA score, right? And when the pediatrician said, your baby got erythromycin in the eyes, he said, yes, she did. And when the pediatrician says your baby got vitamin K, he said, yes, he did. So that gives you, makes you very part of the baby's management to start with, right? Because you get information. Information now is up to date about the baby's first few hours of life. And that's powerful for parents to know because some of this information is going to be part of the baby's story as the baby gets older, right? Time of birth, the ABGA score, the shots they've received, and so on and so forth. So I thank you for listening to this podcast. Please, for you to share that with your friends and families and whoever has a baby who can need this information, because I think this information is powerful. And I hope if you're outside United States or even in Nigeria or Ghana or any so-called poor countries, and you have to find out from your obstetrician or gynecologist whether your baby is getting vitamin K after birth, whether your baby is getting erythromycin ointment after birth, right? Find out from a pediatrician as soon as possible. Find out from the OBGYN doctor as soon as possible before you even leave the hospital, because you don't want your baby to be infected with gonorrhea. That's going to cost a lot of cost to treat afterwards, right? The infection goes in an eye and could be debilitating to the eyes. So you want to make sure your baby got vitamin K to prevent them from bleeding, right? These are very easy things to ask and demand, and they're not expensive, right? But if you don't ask the right questions, you might lose your baby. Your baby might become sick to the extent that it takes a lot of time and effort to care. And this is a baby you've carried for 9 months. So you need all the information you have to make sure the practitioners, the OBGYN doctors, the pediatrician, no matter where you are in the world, that the baby received erythromycin ointment, right? To prevent gonorrhea should that happen, right? Right? You want anything prophylactic that will prevent that is necessary, right? And vitamin K is necessary. So, I think this is a very good topic. You could, begin a discussion with people around you, right? See what's going on in your neighborhood, where you live, all right? Where you deliver your babies, what's going on? and asking questions and demanding answers, right? Demanding answers that these things be done as part of caring for a newborn. Thank you so much for listening. This is Dr. Anselm Chubike Anyoha, MD, PhD in infant mental health and early childhood development, a pediatrician for 30 years. So I think I have some vital information to share with the public and the world. Thank you.